room and online. Super excited. We have a really excellent guest today, Maura Shirey, who's a retired nurse, a national board certified health and wellness coach, and owner of Bodies for Birth, a women's health and wellness company specializing in fitness during pregnancy and postpartum. Maura has earned numerous certificates in the field of prenatal fitness and, sorry for that, provides evidence-based education and programming to clients and providers. Maura is a contributing author to the revised edition of Exercising for Your Pregnancy, I got published, with Catherine Graham, who's with us today. She's one of our other honored guests, and is currently working with her first book and writing her first book, Empowered Through the Process, Physical and Mental Fitness for Pregnancy, Childbirth, Motherhood, and Beyond. So this is a topic I thought all of us could benefit from, learning how to support our patients and ourselves with our patients and exercise and healthy pregnancy. So I'm going to kick it off and turn it over and hopefully you enjoy. Thank you so much.
Thank you so much for having me. Thank you, Dr. Hoppy. Okay, it might take me a moment here. I'm navigating two screens. So, good morning. The title, do you guys want me to stop?
You don't have to fix it. Yeah, we're really good.
Should I stop?
We have IT.
No.
I told Maura, I go to Sonia from the problems too, so she'll fix it.
This one's mine. I don't know if you know
I love people.
it.
Just for you, yeah.
Is any better?
Yeah, there we go.
All right, so good morning. My name is Maura Shirey, and the title of today's presentation is From Walking to Walking Handstands, Navigating the Conversation Around Exercise and Pregnancy with Confidence. All right, so I have no relevant financial disclosures, but I do have plenty of acknowledgements. So I am so honored and humbled to be here with you today, and I did not get here on my own. So my deepest thanks to the many members of this University of Wisconsin-Madison team who have helped make this trip possible, and to all of you who are here in person and online joining me to learn this morning. It's truly an honor. At Bodies for Birth, I value diversity, equity, and inclusion in all that I do in an effort to honor each individual. With that in mind, for the purposes of today's presentation, I will be utilizing the term pregnant person, pregnant individual, and I will be using they, their, and them pronouns, except for in the event when I'm citing a resource that uses woman, women, they, she, her, or hers. So, who am I and why am I here? I am here because in 2013, I stumbled my way through exercise in pregnancy with my first son, and ever since then, I have been on a mission to provide evidence-based research through heart-centered education. But back to the stumbling. Just a moment here. As a former athlete, nurse, and wellness enthusiast, I found it completely confusing and overwhelming to navigate the prenatal fitness landscape. Now, despite resources, motivation, and a commitment to stay active, I was really disheartened. I did my best to piece things together, and all along I couldn't help but wonder, if it's this hard for me, with the motivation that I have, the commitment, the resources, what must it be like for other people without similar privileges? So when it came time to labor, we found that baby Will decided to move through the birth canal sunny side up. So we labored for quite a while, which included 4.5 hours of unmedicated pushing before he was born. And for my provider, she felt like my fitness level, and in particular Will's ability to recover throughout the labor, were her primary reasons for allowing me to continue to labor as opposed to move toward a cesarean. So each one of these experiences planted seeds. And in 2014, with 6-month baby Will strapped to my chest, I set out on a mission to improve healthcare for moms and babies everywhere. And you can see Will now, almost 12, and Johnny, who conveniently arrived with 2 pushes at lunchtime. So Will really paved the way there. Okay, so since the very beginning, I have utilized my various training venues as my labs, and today this looks like the virtual setting. Each has been a space to be curious, to listen, to learn from the community. And really, while the foundation of what I do is fitness, truly, it's about love. It is about supporting people not only to survive, but to thrive in pregnancy and on into parenthood. It's about the synergy between mental, emotional, and physical health. And today, I'm here to share what I've learned over the past 11 years to dispel myths and misconceptions, and most importantly, really to empower all of you to have these conversations around exercise in pregnancy with your patients, your clients, and within the community. So it's confusing. Let's just begin with that. The pendulum has swung when it comes to this field of exercise and pregnancy. 11 years ago, I met with clients who were full of fear, some who were prohibited from movement out of cultural or familial expectations and pressures. Others feared exercise for various reasons, maybe because of previous miscarriages or fertility treatments. But there was just this overarching feeling of fear and confusion and insecurity when it came to moving their pregnant bodies. Now, in the past 11 years, there has been significant progress when it comes to research and accessibility to pregnancy-specific programming, of course, with varying degrees of credibility. And there's a general understanding that movement during pregnancy is safe and beneficial for most. So the momentum of this pendulum swing also means that a quick scroll through social media can find high-level athletes performing things like this, including walking handstands at 39 weeks. Now, while clearly this is a super impressive act of athleticism, it can translate to shame, to greater confusion, to unreasonable expectations for the recreational athlete or for the sedentary person who's not living up to these social media reels and ideals. Now for Annie, she's a professional CrossFit athlete. Perhaps this was appropriate or more in the sense of something that she would do typically, but not for the majority of the pregnant population. And more importantly, it is not in line with current exercise recommendations due to the risk of trauma to the abdomen in the event of a fall. So I think there's some danger around these sorts of images. In preparing for this presentation, I decided to do a little experiment, and I pretended that I knew nothing about this topic. I wanted to see what a pregnant person might find in 2025 if they simply Googled, excuse me, the question, is it safe to exercise in pregnancy? So ACOG says, yes, it's safe, and expands upon that to show that exercise does not increase the likelihood of miscarriage, low birth weight, or preterm birth. ACOG goes on to express the importance of consulting with the provider and indicates that the provider should be able to provide the exercise prescription. Now, Johns Hopkins has a bit more information, including benefits. They also cite ACOG, and again, recommend that the healthcare provider can consult and provide guidance. Excuse me. Okay, so next we get to see what an AI synthesis of information presents. And so Google shares that it's generally safe, but also indicates the importance of getting provider clearance, and again, suggests that the provider can provide a recommendation, including personalized recommendations from ChatGPT, again, generally safe. But you can see from the circled areas that they also suggest medical supervision and guidance. So what do they all have in common? That the providers hold the answers. And you do. You have many, many answers to many, many things. But this expectation doesn't feel entirely fair to me when you are already experts on so many other topics, arguably many of which are of higher priority during individual patient visits. So we'll get to that a little bit later. Oh, sorry, forgot to go for it. Providers who hold the answers. Next. But generally, patients want to be healthy, but they often don't know how or where to begin. The recommendation, as we've seen, is to seek guidance from the provider, and yet providers often don't have the training, the education necessary to provide this form of nuanced guidance. So we have confusion, we have barriers, and the research does back this up. A 2020 study in Health Psychology Review shared the following. Faced with conflicting or inconsistent information from professionals, women often sought information from other sources, such as books or the internet. And most importantly, they relied on lay advice to inform their decision-making. Research published in Maternal Child Nutrition in 2021 discussed the barriers you see listed here for both pregnant patients and for providers, and this supports previous research findings. So You can see some of the top ones here: limited time, cost, family responsibilities for pregnant people, for providers, education, resources, and time, I think, is a really big one. Very importantly, social determinants of health, such as the ones listed here, contribute significantly to patient barriers, and I do not think we can underestimate that. Let's take a look at what's happening in Wisconsin locally. So in this slide, we are looking at Wisconsin pregnancy characteristics as reported by the Wisconsin Department of Health Services Vital Records Data Dashboard for 2023. 40.4% of patients who gave birth in Wisconsin in 2023 had at least one risk factor. That's up from 35.1% in 2018. And more specifically, in 2023, 48% of persons who gave birth and resided in Dane County had at least one pregnancy risk factor. It's really hard to read those there. So the risk factors, I'll read them to you, include chronic or gestational diabetes, chronic or gestational hypertension, preeclampsia, eclampsia, previous preterm birth, cesarean delivery, or poor pregnancy outcome, or a pregnancy that resulted from infertility treatment, fertility enhancing drugs, or assisted reproductive technology. So experiencing one or more of these risk factors then in turn sets the patient up for future risks, including adverse pregnancy outcomes. And unfortunately, we know that people with adverse pregnancy outcomes then go on to have higher future risks, including cardiometabolic disorders later in life. Okay, and as we know, obesity and overweight is a concern nationwide, and here we can see what's happening for people in Wisconsin, particularly of women of childbearing age. So beginning pregnancy with overweight or obesity is associated with a multitude of health considerations for both the pregnant patient and for the baby during gestation and beyond. It's important to note that it's not uncommon for this population to be met with discrimination or stigmatization. Our job is to confront our own weight biases as applicable and to meet each individual with compassion. Big Fat Pregnancy resource I have listed here is an excellent place to start. They have something called size inclusive provider training, which is very helpful. Okay, let's take a closer look at the data. So most recently in 2023, 36.5% of women classified, ages 18 to 44 were classified in the obese category. So that's defined as a BMI greater than 30. In 2022, 27% of mothers had a pre-pregnancy BMI classified in the same category. And in the same year, 31.9% of mothers had a pre-pregnancy BMI classified as overweight between 25 and 29.9. So this is where we're starting from, and it's a considerable amount of the population that will benefit from our compassionate care and our education. So the statistics are sobering, and the confusion is real. The barriers are many, and yet the opportunity for health promotion through the opportunity for improving maternal health outcomes through health promotion is great. So I believe that providers are key to making progress, not by being the experts in this field, but by starting the conversation, by letting patients know that it's safe and important to exercise in pregnancy, that it's not just a nice idea or something to do if they have the motivation or if they have the time. If we hope to make real progress, I feel it must be a priority. Okay. So let's move on to our learning objectives. So there's work to be done, and I have 5 learning objectives for us today. The first one is for you all to have the opportunity to identify your own comfort and confidence around this topic. The next is to identify current prenatal exercise guidelines and dispel myths and misconceptions. Beyond that, we're going to work on identifying evidence-based research on the benefits, discuss the relative and absolute contraindications to exercise in pregnancy, and then at the end, you have the toolkits in your hand. If you're here, we'll utilize a toolkit to help you to navigate this conversation with people across all populations. So learning objective, let me catch up here, learning objective number 1. With this one, I aim for you to have an opportunity to really think about your areas of comfort and confidence when it comes to discussing exercise in pregnancy with your patients. So please take a moment to consider the next 5 questions. So question number 1, how comfortable are you discussing exercise in pregnancy with your patients? So from not comfortable at all to very comfortable. Question 2, How confident do you feel in sharing your knowledge around exercise in pregnancy with your patients? Again, from not confident this time at all to very confident. Question 3, how often do you share information around exercise in pregnancy with your patients? From we talk about it throughout, at least once, only when asked, or perhaps never. Question 4, how confident do you feel connecting patients to evidence-based resources regarding exercise guidelines in pregnancy? And the final question here. How comfortable are you in adapting education to your patients' individual needs? From not comfortable at all to very comfortable. So with your responses in mind, just consider your strengths and where there's an opportunity for further learning. Okay. Moving on to learning objective 2. Here we summarize current prenatal exercise guidelines, and I'll get into dispelling some of the myths and misconceptions related to these guidelines. Alrighty, so while there are numerous worldwide guidelines for exercise in pregnancy, many of which overlap, I'm basing today's presentation on the 2019 Society of Obstetricians and Gynecologists / Canadian Society for Exercise Physiology recommendations for their rigorous development. Despite the strength of these guidelines, I'd like to acknowledge the fact that they are in essence a moving target due to the nature of research, scientific discovery, and best available evidence, as you all know. So we can use these guidelines as our framework, recognizing that there's more nuanced and current information becoming available all of the time. So you can see a bird's eye view here and some of the common myths, and we will get into those next. Alrighty, we'll go through them one by one. So recommendation number 1, all women without contraindication should be physically active throughout pregnancy. Specific subgroups were examined. Those subgroups included women who were previously inactive, women diagnosed with gestational diabetes, and women categorized as overweight or obese. This brings us right to our first myth, which is if you have not been exercising, don't start during pregnancy. So 12 systematic reviews debunked this thought, and individuals who were previously inactive gained some of the greatest benefits by beginning an appropriate exercise program. With that in mind, of course, we're going to start slowly and progress slowly. It needs to be individualized. So any amount of time over what the individual is currently doing counts as progress. Let's move along to recommendation number 2. Pregnant women should accumulate at least 150 minutes of moderate intensity physical activity each week to achieve clinically meaningful benefits and reductions in pregnancy complications. So great, we have this number, we have 150 minutes, but what is moderate physical activity? So examples include brisk walking, stationary cycling, water aerobics, and swimming, maybe for some, but how hard is moderate physical activity? In the absence of very specific monitoring, it's a subjective measurement based on each individual's perception of their effort and their exertion. So essentially it becomes an N of 1 in many ways. Now technically the SOGC CSEP recommendation of moderate physical intensity is defined as 40 to 59% of heart rate reserve, corresponding to reserve oxygen uptake. This takes quite a bit of math to calculate and is really an impractical approach in practice. So instead, we can use familiar language and experiences to approximate moderate physical activity. So it's hard enough to feel like you are working. It allows the individual to still have a conversation so they can talk but not sing. Another way to measure this exertion is through the use of the Borg scale. So using a 6 to 20 point Borg scale that you see here, somewhere within that 12 to 14 range would be considered moderate physical activity. Now there's more nuanced research becoming available that breaks down the ranges based on heart rate and age group, but I think for our purposes, shooting for a 13 on the scale makes good sense. This speaks directly to another myth featured here, which is it's not safe to exercise at greater than 140 beats per minute. Growing evidence in the last 40 years has shown that exercise intensity to 80% does not result in fetal bradycardia or distress. With that in mind, there's still very little research on the upper threshold in terms of both volume and intensity. So the lack of consensus then leaves us with a somewhat cautionary recommendation of 150 minutes at moderate intensity, despite studies showing that there's, no adverse effects of higher intensity exercise, but still high level athletes should be monitored in a collaborative way. And we'll talk about that more coming up. A few more considerations regarding heart rate include both wearables and blood pressure medication. So what about wearables that have become so popular, things like Fitbit or a Whoop Apple Watch? Unless the individual is an avid exerciser, competitive, or professional athlete, one possibly accustomed to using and interpreting that data accurately, I feel like those wearables are less valuable in terms of interpreting intensity as opposed to using the Borg or the talk test because of the cardiorespiratory changes in pregnancy. When it comes to blood pressure medications, if your patient is on blood pressure medications, you need to be informed of how blood pressure medications impact their heart rate response in terms of exercise. So these patients demonstrate another instance in which heart rate may not be a reliable predictor of exertion, and again, should be informed to use the Borg scale that you see here or the talk test. Okay, so back to our recommendations, moving on to number 3. Physical activity should be accumulated over a minimum of at least 3 days per week. However, being active every day is encouraged. So why 3 days? The researchers found that activity must occur over at least 3 days per week to see a 25% rate of risk reduction in pregnancy complications. So the higher the frequency, as in the more days active, the better. Recommendation number 4, we're moving down to the bottom row here. Pregnant women should incorporate a variety of aerobic and resistance activities to achieve greater benefits. Adding yoga and or gentle stretching may be beneficial. Researchers noted that there's very little evidence to this, but that some resistance training was beneficial, and also of note, yoga and stretching should be incorporated above and beyond the 150 minutes of recommended activity. Yoga was primarily used for the mental health benefits without adequate research to support its reduction in pregnancy complications, which I find particularly interesting, as prenatal yoga is one of the most commonly recommended and cited forms of prenatal exercise. Moving on to the next myth, avoid abdominal exercises in pregnancy. So while avoiding some of the more traditional abdominal exercises that are going to focus on the rectus abdominis, those are the six-pack abs, that we're going to use plenty of other appropriate core exercises. And in fact, it's really important to have a strong core throughout pregnancy to help to reduce musculoskeletal imbalances and some of those common aches and pains. Moving on to recommendation 5. Pelvic floor muscle training, for example, Kegel exercises, may be performed on a daily basis to reduce the risk of urinary incontinence. Instruction in proper technique is recommended to obtain optimal benefits. Researchers acknowledge that this is a weak recommendation with low quality evidence, and yet it remains important because up to 75% of women experience urinary incontinence in pregnancy, and for many this persists well into postpartum and can dramatically impact quality of life. So researchers emphasize the importance of proper guidance and attention to the relaxation phase of the activation. So as it says here, this should be pursued with guidance from a women's health physical therapist. I've included a link to APTA Pelvic Health, as they can help patients to find local women's health physical therapists throughout pregnancy and postpartum. And important to note that an experience with a women's health physical therapist is going to be quite different than a traditional sports physical therapy or rehab physical therapy experience. Moving on to our last recommendation. Pregnant women who experience lightheadedness, nausea, or feel unwell when they exercise flat on their back should modify their exercise position to avoid the supine position. So the concern here is the compression of the inferior vena cava when supine, leading to a decrease in venous return, which can result in symptomatic hypotension. So opposed to the supine position, the pregnant person can be moved to their left side or use bolsters, blocks, pillows to sit more upright. But symptoms of hypotension must be addressed at any time during pregnancy, particularly if this occurs during exercise, the exercise must stop. So a final note, so while these guidelines are representative of some of the strongest research to date, the authors recognize limitations, including the following. The studies were primarily based on aerobic exercise, often walking. There was limited information, like I've already said, around resistance training or yoga. Typically, the studies were in the scope of previous studies, so less than 45 minutes and a few days per week. And again, there's minimal information regarding higher intensity and volume, pointing us in the direction for future research. just about done with learning objective 2, but before we wrap up, there's a lot that pregnant people can do to stay active, but it's really important that we're also aware of what they should avoid. So things like physical activity in excessive heat, particularly with high humidity, as there's increased risk of fainting and dehydration. Activities that risk trauma to the belly, think of Annie at the beginning. And of important note, this can include some other things such as contact sports, horseback riding, riding a non-stationary bike. Of note, even experienced athletes cannot control or always control their environment or account for the changes or activities of baby. Think about kicking, that sort of thing. So it's wise to avoid any activity that may present a risk for a fall. When it comes to scuba diving, there's no known safe depth. Caution with activities, of course, that are jarring, ballistic, involve quick turns. And here's an interesting note on altitude awareness. So there is scarce research regarding exercise at altitude. The current Canadian guidelines, however, share that the combined impact of exercise at altitude above 2,500 meters and pregnancy is unknown for lowlanders. So meaning women born and living less than 2,500 meters. So the Canadian guidelines suggest lowlanders should avoid exercise at altitudes greater than 2,500 meters, but note that this is not applied to individuals born at altitude. So I did a little digging around in the research here and found that there are nuances to this particular recommendation based on the exact altitude, the length of time spent at altitude, and then so that can include short-term visitors versus short-term residents, and then also in addition to the intensity of exercise. So all of this is to say, I think this is a gray area, but it's worthwhile to note if you have patients traveling to altitude. And I have a few interesting links to research on this topic if it's something you are interested in. Okay, so a final note before we move on. Despite the growing body of evidence that supports exercise in pregnancy, the individual must be comfortable with their level of activity and in the recommendations they follow. In the event of a poor outcome, the mind will create a story. It will look for a cause under these circumstances. So if the pregnant person was carrying out an exercise prescription they did not feel comfortable with, they might prescribe blame on themselves, the program, or the outcome. So in my personal experience, I therefore always aim to provide evidence-based guidelines, measures for safety, education, all of this in an effort to empower the pregnant person to ensure that they're appropriately active at a comfort level that feels right for them, recognizing this is a very complicated multifactorial relationship. Moving on to learning objective 3. We're going to outline evidence-based research on the benefits of exercise in pregnancy, which there are many. So in the absence of contraindications, following the guidelines set forth by the SOGC, CSEP is associated with benefits for both the pregnant person and for baby. Prenatal physical activity can and should be considered first-line treatment for improving overall maternal health outcomes while reducing the risk of pregnancy complications. Highlight a couple of the benefits for the pregnant person: decreased risk of preeclampsia by 41%, decreased risk of gestational hypertension, we see 39%, decreased risk of gestational diabetes, 38%. Moving over to baby, highlight a couple there too: fewer newborn complications such as macrosomia, reduced BMI after birth, improved neurodevelopment. So patients should know that every minute counts. They can start low and go slow and will still reap the benefits of physical activity, even if they aren't meeting the current recommendations. So in fact, walking for just 10 minutes per day will reduce the risk of preeclampsia by as much as 25%. Of note, the impact on cesarean delivery appears to be mixed at best, and quite unclear. But with that in mind, fitness going into delivery, regardless of the mode of delivery, will set the patient up to tolerate labor better and for a better postpartum recovery. Okay, so moving on already to learning objective number 4, identify relative and absolute contraindications to prenatal exercise. So while exercise is beneficial and appropriate for most, there are instances where modification is necessary above and beyond what we might expect in a healthy pregnant person. So 2 categories are identified here, both absolute contraindications and relative contraindications. So pregnant people with absolute contraindications may continue their usual activities of daily living, but should not participate in moderate to vigorous intensity activities. It may be hard for you to read those there, so let me read them to you. Absolute contraindications include ruptured membranes, premature labor, unexplained persistent vaginal bleeding, placenta previa after 28 weeks, preeclampsia and confident cervix, intrauterine growth restriction, high order multiple pregnancy, for example, triplets, uncontrolled type 1 diabetes, uncontrolled hypertension, uncontrolled thyroid disease, and other serious cardiovascular, respiratory, or systemic disorders. When it comes to pregnant people with relative contraindications, this is a conversation between the patient and the provider around the advantages and disadvantages to exercise at a somewhat higher level. So again, I'll highlight these for you here. Relative contraindications include the following: recurrent pregnancy loss, gestational hypertension, a history of spontaneous preterm birth, mild or moderate cardiovascular or respiratory disease, symptomatic anemia, malnutrition, eating disorder, twin pregnancy after the 28th week, or other significant medical conditions. So additionally, pregnant individuals should be aware of warning signs that should encourage them to stop. Things like vaginal bleeding, abdominal pain, regular uterine contractions, amniotic fluid leakage, persistent excessive shortness of breath, dizziness, headaches, severe chest pain, muscle weakness, calf pain and swelling, decreased fetal movement. And I'll add, the pregnant person should stop if something does not feel right. Bringing us to our final myth. If you develop an absolute contraindication in pregnancy, you should limit all activities. Well, we just debunked that here. So while the avoidance of strenuous activities is recommended, bed rest is not. Research has shown that bed rest can result in muscle and bone loss, thrombosis, early delivery for baby, and depression. So all pregnant individuals should continue to participate in irregular activities of daily living, unless specifically indicated by their provider. And these sorts of activities in the for the absolute contraindication patient include things like going to prenatal appointments, walking to the mailbox, those sorts of things. I think that's a bigger conversation, but I'll leave it at that for now. So finishing up with learning objective number 4, beyond making general recommendations, an opportunity for you here to consider how you might advise the following diverse populations, including those patients with relative or absolute contraindications. So take a moment to consider what you would suggest in the following scenarios. High-risk patient with absolute contraindications versus one with relative contraindications. A patient with gestational hypertension, one with gestational diabetes. A patient with overweight or obesity and new to exercise. One undergoing IUI or IVF. A patient fearful of pregnancy loss related to exercise. And a final note here, while the research supports continuing with ADLs, as is just stated, are there circumstances in which you believe that bed rest is warranted? And if so, how could you support this patient in terms of movement? So from these examples, you can see just how difficult and complex this conversation would be. And the intention of learning objective number 5 is to help you to navigate this conversation with much greater ease. So let's get right to that. We're moving into our toolkit. My aim is to provide tools so this conversation becomes much more accessible for you and for your patients. All right, so if you're here in person, you have hopefully a green folder, and that is your toolkit. And you can see all of the things that are listed, that are within the toolkit listed here. If you are online, this will be emailed to you afterward. So while we've explored that the general recommendations look like, we know that there's never a one-size-fits-all prescription. So this toolkit encompasses resources from Bodies for Birth, from the Canadian Society for Exercise Physiology, as well as others for your use in navigating these conversations. Alrighty, so let's get into the provider tools. Okay. To navigate what can be a sensitive conversation around the topic of fitness, here's your first tool. So this particular tool is a fusion of motivational interviewing techniques, compassion practices, and behavior change theories to help you in meeting patients at the juncture of change, utilizing a healthy dose of compassion. The expanded explanation on how to use this tool is on the back side of your handout, but for our purposes, we'll review it in brief. So I want you to allow this to be your big picture framework, and the 4 C's stand for curiosity, compassion, connection, and collaboration. In step 1, we begin with curiosity. So if time allows for conversation, you can always use open-ended questions, such as how do you feel about your fitness level and your health, to learn more about your patient. Through additional follow-up questions, you can help them to identify a gap between their current health and where they'd like to be, or their intended health. But what's more likely is that time is scarce. And so in lieu of, or in addition to a very brief conversation, you or a support staff member can offer the patient a CSEP Get Active questionnaire for pregnancy for completion. That's coming up in the toolkit, but there's a copy in your folder. And this gives you a window into the patient's activity and really opens up the door for this conversation and for the following steps. Step 2 is all about compassion. So this step takes barely any time at all and is beneficial for both you and for your patient. So compassion towards your patient can feel like a soft smile, eye contact, a pause in the conversation to appreciate them and their lived experience. Compassion for yourself, which I think is equally important, can feel like a deep breath or a sigh, like moving your body in a relaxing or relieving way. It can be placing one hand in the other hand and rubbing the top of your hand for a moment. No one is the wiser, and truly everyone will feel better. Step 3 is all about connection. So this is where you connect the patient to resources such as the CSEP guidelines, evidence-based education, or perhaps local resources within your community. Step 4 is collaboration. So I truly believe that it takes a collaborative approach to support not only our patients, but ourselves. So having trusted referrals helps to bridge that gap between specialties and allows for comprehensive continuity of care. I personally offer complimentary consultations to every provider so that we might provide and partner to provide the best care possible for your patients. So if this feels like a lot, just rest assured that even using one of these C's, remembering one of them, can be powerful in terms of making a difference with your patients. Let's move along to moving along in learning objective 5. Your second tool in your toolbox is meant to be a roadmap, utilizing the 4C framework to navigate conversations on prenatal exercise with your patients. So if you're in person, you got a laminated copy. It's laminated so that it can just be in an examining room and just be used easily until it's something that just feels very natural for you. So the purpose of this roadmap is to demonstrate the complexity of how patients break down and how it's quite difficult to apply that one-size-fits-all prescription. So beginning at the top, we can see that the conversation begins with curiosity, as I mentioned, through open-ended questions or perhaps just through the use of this questionnaire. And from there, patients break down into 2 different categories, either cleared for activity in the green box or provider consultation required. So the conversation from here is going to continue with compassion, especially for those patients who are not cleared for exercises. It can incite quite a bit of anxiety on their part. So if they are cleared for activity, they break down again into not currently active or currently active. The not currently active patient is encouraged to begin an exercise program. The currently active patient is encouraged to continue, perhaps with some modifications depending on their current program. When it comes to the not currently active patient, when it comes to the patient who is not cleared for activity, there's an additional form also in your toolkit for healthcare provider consultation. So these patients will require some additional guidance, modifications, and conversations. They break down again, like we've already seen, into relative or absolute contraindications, and we've already discussed what that looks like for them. But regular follow-up for these patients, monitoring and modification will be necessary. The conversation at the bottom continues through connection to resources and collaboration. The back side of this handout is just meant to be your at-a-glance guide for recommendations, guidelines. The Canadian guidelines are listed there, things to avoid, knowing when to stop, my contact information for your consultation if that's helpful to you, and then a reminder that if there's a change in pregnancy, reevaluation is necessary. Okay, so we're coming up to the 2 forms that I mentioned. I think these forms are amazing tools from CSEP. The first here is the Get Active for Pregnancy Questionnaire in Detail. So this is actually meant to be a self-administered tool, but for the patient, for them to determine their own readiness for activity. But this form would likely be very hard for a patient to find unless they were looking for it specifically. So with that in mind, I propose the action of distributing this form at the first prenatal visit, or ideally at a preconception visit if you have that opportunity, so that you can begin the conversation around exercise and pregnancy in general. So the form asks several questions of the patient regarding both their physical activity and their pregnancy. If they answer yes to one or more of those questions, they're cleared for activity. If they answer no to one or more of those questions, they are prompted to use that healthcare provider consultation form, just like we saw in the roadmap. So moving on to that, it looks like this. So you can see that they're relative, or hard to see here, easier to see in your folders. The blue column there lists the absolute and relative contraindications. And then we also have the guidelines on the second page. So this form really provides an opportunity for that conversation between provider and patient regarding those specific concerns. There are a variety of ways that the provider can reply and advise, including referral to a qualified exercise professional, to a women's health physical therapist. Okay, let's move on to patient tools. Get that here. So patient tools, very similar to the provider roadmap. This handout is meant to help the patient understand how to navigate pregnancy or exercise in pregnancy. Page 1 walks the patient through step by step. You can see in that blue box on the healthcare provider consultation side required a little more verbiage there and tenderness, just to allow them, let the patient know that there are still ways that they can stay active, even though it may not look as look like what they had hoped. Backside, again, as it was with the provider handout, meant to be an at-a-glance guide, but there's a little bit more here, including the top green box, knowing when to start, or I'm sorry, knowing how to start. And then very importantly on this handout is a blue column for guiding questions for self-reflection. These questions will help the patient to check in throughout pregnancy to know when modifications are necessary and should be considered on a regular basis. All right, moving right along. So impossible to read, of course, for you here. You can take a look at it in your handout, and we'll go into each level in more detail next. But this tool was a bit of a passion project and was originally created for the patient, but I'd like to demonstrate how it can be helpful for both the patient and the provider. This is really where we get to apply the information that we've learned today and create a plan for movement. The template is called the Progressive Prenatal Exercise Design Program design, and it's based on fitness level. So this is intended for use by the healthy patient without contraindications. The idea is that the individual can take a look at this template and determine where they're starting from based on their fitness level, with the goal of advancing to the moderately active category. The categories are new to exercise are currently sedentary, lightly active, moderately active, and highly active, with each category having its own unique recommendations for activity broken down into the columns you'll see at the top. Those columns include exercise intensity, exercise type, which is aerobics, resistance training, pelvic floor muscle training, yoga or gentle stretching, frequency, duration, suggested weekly total, and then notes. So I'd like to look at these in more detail next. All right, so the first category, this is our new to exercise or sedentary patient. So we are meeting the individual at their current level of activity, whatever that might be, including walking to and from the car, walking up or down stairs once a day, however minimal. The focus is less on the specific type or quantity of movement and simply on incorporating more movement in any gradual amount above and beyond what they're currently doing. We encourage the individual to track their movement week after week, to celebrate all successes, and then to view course adjustments as learning opportunities. We encourage them to progress to the lightly active category when their current level of activity begins to feel easy. So you can see here on the board scale, we're at about a 7 to a 9. So that's really in the extremely light to light category. And our key takeaway for this population is to meet the patient with compassion and baby steps. So the focus is on simply incorporating enjoyable or tolerable movement in any gradual amount above and beyond their current level. Moving on to the next category, we have lightly active or occasional exercise. So in this second category, we are again meeting the pregnant person at their current level of activity. But this time they may already have some activity that they're doing occasionally or inconsistently. So assuming that these are activities that they enjoy, we want to encourage them to continue doing these activities and gradually increase the quantity so that they can move to that moderately active category. If they're not enjoying the activity that they're doing, my personal opinion is that we should help them find something or encourage them to find something that they do enjoy, as this will increase adherence to the program, can sustain, and of course, improve their overall quality of life. So like we did with the first category, we encourage the individual to track their movement week after week, to celebrate all successes, and then to use course adjustments as learning opportunities so that they can advance to that moderately active category when the current level of activity feels easy. We've moved down a little bit on the Borg scale. You can see now we're at that 10 to 12, so still in light, maybe on the cusp of somewhat hard. And our key takeaway for this group is more of what they enjoy. So focus is on gradually increasing exercise so that the patient can advance, again, to that moderate level of activity. Next level is moderately active. When we consider that only 25 to 30% approximately of pregnant patients worldwide meet physical activity guidelines, the people that fall into this category should both be acknowledged for their efforts and encouraged to continue. As we've seen with the previous two levels, we are again meeting the patient where they are. This time they're right in that Goldilocks zone for exertion and for intensity. So we can share evidence-based resources and activity recommendations to modify their programming for pregnancy. We can share that they're right on track. And the challenge for these patients might be just keeping them active throughout for the duration of their pregnancy. So education related to modifications as pregnancy progresses and regarding the benefits for both pregnant person and baby can help these patients to keep moving. So like we've done in the previous two categories, we're going to encourage them to track their movement week after week, celebrate successes, view course adjustments as learning opportunities. This time we encourage them to stay right in this moderately active category. So the moderate intensity level here and volume is where most of the research has been done around exercise and pregnancy as being beneficial for both mom and baby. So that's why we keep them, or encourage them to stay in this area. We've moved down a little bit again on the Borg scale. Now we're at a 12 to 14, and our key takeaway for this group is acknowledge and encourage. So these patients are already on the right track. We want to assist them to maintain consistency throughout pregnancy. Alrighty, we're moving on to the last category, and this is the highly active patient. In this fourth category, we are honoring the value placed on fitness and health in the highly active individual's life. So this person prioritizes exercise already, and they may struggle to adapt their current routine to pregnancy guidelines that may feel like less than or inferior to what they're accustomed. I know nothing about this, of course. They can present a real identity shift on the part of the patient who is struggling to share their body with pregnancy. So I'm always very cautious to walk a fine line in the recommendations here. A few things to keep in mind. Fitness is likely part of who they are. And so an approach to their programming in pregnancy may fall outside the standard guidelines, but this programming should be a collaborative approach with you and with other healthcare providers, including regular monitoring of both mom and baby. The pregnant athlete can be a real paradox. So it's someone who knows their body and its capabilities very intimately, and at the very same time is someone who is also very intimate with pushing their body to extreme levels. So with the permission to still challenge themselves and with a team of collaborators, pregnancy can be a very empowering experience as they learn to work with their body in a new way. So at this level, it's important that we inform the pregnant person that there is not a clearly defined upper threshold for intensity and volume, and help them to create that collaborative care team to monitor and modify. This individual must be provided with anticipatory guidance around what to expect in terms of modifications as pregnancy progresses, and should be assured that modifications do not equate to becoming deconditioned. Modifications are how the pregnant athlete stays active throughout their pregnancy. So we're looking a little bit lower on the Borg scale, and you can, in the column exercise intensity, you'll see that the advice is to stay below 80%. Honestly, this is going to end up being up to the individual, but this is what's recommended to share. So when it comes to our key takeaways for this population, educate, modify, monitor, and empower. So the pregnant athlete presents both unique challenges and opportunities. A collaborative approach with education, modifications, and monitoring can create an empowering and safe experience. On the back side, we have just kind of like the other handouts, quick reminders around safety, anticipatory guidance. We have a Borg scale and my contact information. Final tool for patients. a resource that helps patients to put intentional thought into their exercise planning and program for pregnancy. So the boxes are meant to be prompts for planning. So everything from goals to barriers, questions, concerns, support system, their why, and a place to jot notes. The backside can be used to set intentions and make an actual plan for the week. So patients can be, you can make copies for your patients so they can get them from the Bodies for Birth website. Okay, so with all health coaching, we look to a positive future, and I'd like to do that now. Future research. When I first sat down to propose areas for future research, I had a short list of 19 topics across 13 different categories, and I have condensed that into a much smaller list, knowing that I'm still leaving so many topics out. So if anyone's curious about the whole list, I'm happy to send those to you, but I've highlighted a few here. So effects of vigorous intensity exercise, particularly in first and second trimester, upper limit of safe exercise for those exercise enthusiasts, maternal and fetal responses to moderate vigorous activity at altitude for the pregnant lowlander, effects of a collaborative care team approach to patient education on prenatal exercise, effects of employing specifically designed programs for individual special populations, like some of the ones that we've mentioned today, and then efficacy and safety for patients undergoing fertility treatments. Ironically, as I found this research as I was wrapping up the final draft of this presentation, and you can only imagine how overjoyed I was when I found this call to action from the American College of Sports Medicine. So their call to action is directly in line with the learning presented today. I found this article to be so impactful, it's included in your folder. And in line with the Exercise is Medicine initiative, this commentary calls to action the integration of prenatal physical activity prescription, counseling, and referral into primary care. It recognizes pregnancy as an opportunity. It recognizes the patient-provider relationship as full of potential and shares my deep desire to create a more collaborative approach to wellness. So as we wrap up here, a final note on ways that we might collaborate. So since the very beginning, I have vowed to evolve with the needs of the community, and I stand by that promise. So I see the needs of so many communities becoming more dire, and the health consequences becoming poorer and poorer, and poor health outcomes becoming more prevalent. So with this in mind, I feel very much drawn toward creating change within some of these special populations that we've discussed today. But this really does call for a collaborative approach. So an approach that will prioritize individualized patient-centered care, one that will provide for the inclusion of health coaching so that we might create real behavior change, and an approach that's ready to innovate by creating new recommendations for some of the special populations we discussed today. All in an effort to improve maternal health outcomes one pregnant person and baby at a time. So you can see some of my ideas for passion projects here, including the effects of a collaborative approach to patient education on prenatal exercise, particularly around these special populations, including hypertensive disorders, gestational diabetes, overweight and obesity, patients undergoing fertility treatments, and relative and absolute contraindications. So all of this, and we haven't even discussed postpartum exercise, an equally important topic, but perhaps for another time. So my deepest thanks for being here this morning, for your attention, and for learning with me. I'm always available for conversations, emails, calls, and thank you so much.
Thank you so much. It's been a pleasure. I hope everybody here has, taken something in from this talk. We're a little bit over, but our chair has given us a little bit of time for Q&A, so maybe 2 questions or so, if anybody has them. Maura's going to be available for a roundtable on 4th floor McConnell if anyone wants to come, and then Jamie will be putting in a Zoom link if you are online or want to join that meeting virtually and ask more questions. And then also just doing a lot of other things today with exercise education. Yes. But anybody want to ask a question? And then we will take a short break, and then please be back by 8:30 for M&M. Anyone?
I'll just say that thank you so much, and I learned a lot. And it's a really important topic. There was just actually a landmark study on exercise in oncology. There's just and improved cancer outcomes. So there's no question that physical activity is it's good for all our health. But I think that during pregnancy, it's very tricky, and there's been a tricky, over the course of my career, a lot of different recommendations about activity. And so I think the way you presented it is just, concise and straightforward, but there's so much about it that's it's like diet and exercise is just so important for people, but fitting it into our care conversations is just so difficult.
I believe it, yeah.
So I don't know if others in the room have advice on that, people who are seasoned in taking care of obstetrics patients. Maybe you have some advice.
Is it to you? Oh, to me. Yeah, I believe it. And that's exactly why I tried to address, the fact that I don't think it's your job. I don't think it's your job to prescribe an exercise prescription. What I would love is just the conversation to start there, and for there to become better guidelines around what is safe. So does it seem reasonable to hand out something like that Get Active for Pregnancy questionnaire and to start a conversation in that way? Does that feel time prohibitive?
It seems smart to me to send it out, figure out who needs it, make a referral. I think these things should be baked into regular programming, but I'm not an obstetrician, so that's what I'm interested in.
Just in that, like in so many parts of OB-GYN, like the social media world is tough. But I follow a woman who does a bunch of CrossFit and paleo meals and stuff. And when she got pregnant, she all of a sudden became the expert in pregnancy and was did a post that said your OB-GYN will tell you can't exercise in pregnancy, but that's wrong. And it was it's, so I think there's just also a call for again, us having more of a social media presence to say that's not what all OB-GYNs are telling you, and so just a call to action in that space as well.
Well, I was just gonna put a plug. One of our MAs actually runs an exercise in pregnancy class. So if anybody's looking for a place to refer patients to, she has flyers up in all of our clinics, but it's great. Kelsey Steele does it, so it's
So exciting.
I think the problem with surveys is they get I feel like pregnant patients get survey fatigue, right? They have to fill out their Edinburgh and then their GAD, and then some places have lactations, or there's just da 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 da. And then also if you're giving somebody a survey, oftentimes they want to kind of talk about it with you, which can then be challenging, right?
Sure.
So just as an approach, I think it's easier if I love talking about exercise with patients to open the conversation, basically say do what's comfortable. And then it's great to have referral places to be this is where you should go. And then have the survey and all the other stuff with you. So it's for developing the plan.
Sure. Yeah, absolutely. I think time is a huge barrier. So absolutely, any opportunity to just start the conversation and then pass along the referral, I think is a great place to begin.
I also think it's challenging that a lot of even postpartum yoga, right? Classes when you start it, it'll be you should wait until 6 weeks postpartum to start this. It's no, that's not because the companies have their disclaimers to prevent liability, but then that leads to that's the most vulnerable time, right? When people need to be doing movement and things like that. So.
And to address that, I meet with patients as soon as they're ready. And we're not doing anything more than laying a foundation for healing. And proper movement techniques, because the truth is motherhood is very physical, and postpartum they're lifting and carrying and bending and hinging and doing all sorts of things, and so to be able to do it appropriately with a solid foundation of nutrition and health and support in place makes all the difference towards their postpartum recovery. So I agree, waiting 6 weeks is too long.
So I think we'll wrap up there, but encourage everyone to think about this QI research, and incorporate it in your practice. And maybe together we can come up with some ideas to forward this initiative. So I hope you have a good day, and join us if you want later. And thank you.